Good morning, friends. At the outset, I would like to thank Dr. Mahesh for having given me this opportunity. And as the only woman in the panel, I thought I would make my slides a little more decorative than the men, hence the pearls. Diabetic macular edema is one of the most common scenarios that any vitreoretinal surgeon faces in his or her practice. In the next few seconds, I'd like to share with you the options that I consider while managing a patient with diabetic macular edema. My first and foremost emphasis is on systemic control. Know your patient's diabetic control and what medications he is on. For it's well known that worsening of the systemic status is equivalent to worsening of the ocular health, and a 1% reduction in HbA1c values translates to a 25 to 38% reduction in the sequelae of chronic diabetes. The standards of metabolic controls are different in different clinics. These are the standards that I have for my patients. HbA1c value of less than 7%. I'm quite strict and I check each time the patient reports to me for follow-up. A BP to be maintained between 130 by 80, less than that if possible. A fairly normal lipid profile. And I also take a look at the renal status and refer back to the nephrologist whenever there's a need. Be aware of the drugs that your patient is taking. If they are on glitazones or semaglutide, there is chance that the diabetic macular edema can worsen. Have an idea of whether the patient has had a cardiovascular event or an acute thromboembolic episode in the recent past, which will guideline you to the kind of drug that you can use for the intravitreal injection. Also find out if your diabetic patient is pregnant or breastfeeding, in which certain drugs cannot be used. Semaglutide is presently the wonder drug on the block, the new kid on the block, a widely used anti-obesity and anti-diabetic drug which causes non-arteritic anti-ischemic optic neuropathy and worsening of the diabetic macular edema. The pearl number 2, my take-home message, is that laser still has a place in the management of diabetic macular edema. And if it is a non-center involved diabetic macular edema, it can be a standalone therapy and can also be used in combination with the intravitreal injections. If you do not have the subthreshold or the micropulse grid laser, be happy that nearly 66% of the world's population uses the standard laser. Laser also has a rule in eyes with extensive peripheral capillary non-perfusion areas where a peripheral panretinal photocoagulation would result in resolution of the recalcitrant diabetic macular edema. Pearl number 3 is a choice of intravitreal injection. The protocol that I follow is that I start with an anti-VEGF, check the patient's response every 4 weekly. I expect a 20% reduction in the central retinal thickness and at least a 5-line improvement in vision before I call my patient a responder. I follow up the patient every 4 weekly. And if at the end of the first year, the patient needed more than 6 injections, I would shift focus of my therapy to start using steroids, such as in this patient, in whom at the end of 16 months, by the end of 2 years, the macular edema could be controlled. There are certain ophthalmological and systemic factors which can be taken into consideration while deciding on the drug. If you have an associated PDR, VEGF is a drug of choice. An Ozidrex implant would be of choice in a vitrectomized eye. If there are inflammatory biomarkers like hyperreflective foci, both in the retina and the choroid, a subfoveal serous retinal detachment, then a steroid would be a choice. If the patient has an associated glaucoma, I'd be a little cautious in using a DEXA implant, but it can still be used. The systemic factors that I consider are the history of a recent cardiovascular event, a thromboembolic episode, and if the patient is poorly compliant to follow up, I'd use an Ozidrex. I'd use an Osidrex implant. The most commonly used anti-VEGF all over the world is still Avastin. 66.3% of the patients in the United States still are given Avastin. This is the results of the global trend by the American Society of Retina Specialists. And if you look at the toolbox for the management of diabetic macular edema from 1986 to 2024, what is new that we have in 2024? We have the Vabysmo of faricimab, aflibercept 8 milligram from 2 milligram, and we have biosimilars. The biosimilars can be used. They are as strong in durability as the original drug, but they have a shorter track record than the drugs that we have used for the last 15 years. So what is the role of faricimab and aflibercept 8 milligram in 2024? They have strong durability, but not stronger durability in the management of diabetic macular edema. They do not reduce the visit burden, even though they have a dosing frequency of 12 or 16 weeks. And although they cause a greater volume reduction, greater resolution of the hard exudates, this did not translate into better visual improvement. And as switching agents, there is no evidence that they do better. Only 49 to 50% of the patients are early and consistent responders, and we have poor responders who will either require continued therapy, switch to another anti-VEGF agent, switch to an intravitreal steroid, or combination of both. It is left to your choice and decision as to what you should do. But please bear in mind that the first 2 years are the periods where maximum response can be obtained. Subsequently, the visual results taper off. And if you have a patient who has a vitreomacular interface abnormality, or even if a patient who has a diffuse macular edema who is not responding to any other medication, vitrectomy would be a very good option since you're removing the vitreous sump. As in this patient with very significant diabetic macular edema, where a thick, taut internal limiting membrane can be peeled off, like what you do in a compartment syndrome, like the carpal tunnel syndrome, you de-roof the compression abnormality. And this is the end result in this patient. We could achieve a retina which is relatively quiet. But please, last but not the least, please bear in mind that loss to follow-up is seen in about 40% of our patients. Counsel the patient and try to keep them with you. I thank you very much for your patient hearing.
Thank you, madam. We have our next talk by Dr. Thomas Cherian. Madam, in your 30 years of practice, what is the commonest mistake that medical retina people do in managing DME? What do you see? Because a lot of people are doing medical retina in Kerala. And what is the commonest mistake they do? Irregular treatment or improper assessment, or what do you think is the...
What I feel...
On.
What I feel is that you inject too frequently, too many injections. I recently saw a patient who had taken 20 injections in each eye, and with one biosimilar, he developed endophthalmitis. What they started treatment was at 6/9 vision, and it presently blind in that eye. So inject when necessary, but don't inject too much.
In other words, what madam is telling is DME is a pardonable disease. Unlike AMD, you don't have to be very aggressive in treatment, like monthly injection. If you don't inject, it will become a scar, nothing like that. AMD, you have to be a little aggressive. DME is you have to assess the response in 2 or 3 injections and then only go ahead with further treatment. Look for biomarkers. That is very important. Gopal.
Number 2, madam, you said that too frequent injections is a problem. But let me ask you, which is the injection? Like in diabetic macular edema patient who comes to you, what is your first choice of injection?
I can speak frankly, isn't it? I use maximum Avastin. This is the major drug that I use in my practice. I find that it is as effective as any of the other drugs available in the market, and I have the option of adjusting the cost for my patient.
Okay. And secondly, for AMD as well as DME, that is your first choice?
Yeah, that's my first choice.
Okay. And if price were not to be a concern, we will hear from our legal luminaries about that very soon. But if price were not to be a problem, what is your first choice drug in DME and AMD?
I would say that Eylea would be my first choice.
In both?
In both.
Okay.
But this is a condition in which you have the option of performing surgery for the patient. If you do a routine vitrectomy itself, you are removing all the inflammatory sum that is there in the vitreous. And the half-life of whatever is there in the cavity is also reduced to significantly. So your patient does improve with vitrectomy.
Thank you.